Hello everyone, my name is Saira and I am a PhD student from University of Mount Union. I am very glad to share my research literature review with you today, and without wasting any more time, I will just start with the topic. I will just first describe the topic name, which is what are the best practices in place to optimize medication reconciliation at the time of the hospital admission in the adult patients. So, first, I will begin with my clinical vignette, which is about a 65 years old male who presents with the complaint of the painful swelling and the redness of the left leg for 2 days. So, he's a 64 years old male who has a known history of resistant hypertension and dyslipidemia, and he was admitted to the hospital from the urgent care with the complaint of painful left leg swelling and redness for 2 days. Initially, the pain was mild, non radiating, and dull, but it worsened with the movement and was relieved temporarily by taking ibuprofen and acetaminophen. After the few hours, it further progressed and ascended upward into the left thigh. The patient noticed the redness in the left leg too, but without any pusty discharge. He denies lower extremity weakness or numbness. He denies fever, but he had chills on day two of the illness, and he denies history of fall or trauma to the legs. He refuses any recent travel. There is no history of any recent skin infection in the legs, formation of the blood clots or ulcers in any of the legs, and he also denies any cough or shortness of breath at this time. On the past medical history, he had the history of the resistant hypertension, dyslipidemia. And in the surgical history, he had the history of bilateral hip arthroplasty, one done in 2015, and the other one was done in 2017. Regarding the medications, because of his resistant hypertension, he has been taking amlodipine, 10 milligram once daily per oral, carvedilol, 25 milligram twice daily per oral, furosemide, that's a diuretic, 40 milligram once daily, clonidine, zero point 0.3 milligram twice daily per oral, and then for the statins, torvastatin, 40 milligram once daily at the bedtime. And in addition to this, he was also taking over the counter multivitamins. All his immunizations, they were up to date. He had no known drug allergies, and regarding his family history, only the family history of coronary artery disease was positive in his family, and his father, he had MI at the age of 50 years old. Rest of the family history was insignificant. Regarding the social history, he works as a cashier at a local grocery store, and he lives with his wife and a dog, and he denies using alcohol or smoking. For the review of the systems, all the system symptoms, they were negative except in the constitutional symptoms. He did agreed to having chills, but denied having fever. And rest of the system, all the symptoms they negative. On the musculoskeletal examination, he did have left leg swelling and redness, but he denied any pain or limb weakness. Other than that, cardiovascular, pulmonary, GI, neurological examination, psychological, nothing was a positive symptom. On the physical examination, his blood pressure was 150 by 90, respiratory rate was 22, and heart rate was 100, and he was febrile with a temperature of 38.4. Otherwise, he was a well developed, well nourished man. Cardiovascular examination was normal. On the pulmonary examination, he had normal vesical breathing. Bilaterally, I just wanted to point out here that I have highlighted both the pertinent positive and the pertinent negative findings that are important for this patient's symptoms. So that's why I've highlighted the normal vesical breathing here. Other than that, he didn't have any added pulmonary sounds also. His abdomen was soft, not tender, and liver and spleen, they were not palpable. On the musculoskeletal examination, his whole left leg was erythematous and swollen, very tender to touch and palpation, and there was no calf tenderness. That means that the Homan signs was negative. And the left dorsal pedis artery, that was palpable. whereas the right leg examination was normal, and neurologically, all the examination was normal as well. So for the diagnostic test, the CBC showed a WBC count of 15,000. That's definitely elevated. And out of them, 89% were neutrophils. Hemoglobin was normal and the platelet count was normal as well. Renal function tests, they were normal. And the Doppler ultrasound for the left lower extremity, that was negative for the DVT. That's why the Homan's test was negative as well. So, for the assessment and plan of this patient, he is 64 years old male with a history of resistant hypertension, dyslipidemia, who presented with the signs and symptoms suggestive of the left leg non-purulent cellulitis. So he was obviously admitted in the hospital and he was started on intravenous cefazoline by the medical team, and along with the plan to continue the home medications, including the antihypertensive medications. And he was also started on the pharmacological DVT prophylaxis as well. So, there was some interval changes that happened during his hospital stay. So what happened that the next day, he, despite starting the treatment with the antibiotics, he started the symptoms of the chest pressure associated with the shortness of breath and palpitations. On examination, his chest shows signs of pulmonary edema with tachypnea and bilateral basal crackles. Um, the heart examination just showed tachycardia, and however, his left leg was showing some improvement in the redness and the tenderness because of the antibiotics. On the vitals, his pulse was 125 beats per minute. It was regular, and the blood pressure was 220 by 115. And he was having a hypoxia with the oxygen saturation of 88%. So, due to the suspected hypertensive emergency, the pulmonary rapid response team was called, and the patient was transferred to the medical intensive care unit, and then the antihypertensive treatment was started. So, all these changes that happened about this patient, that raises two questions. So, what went wrong and was it preventable? So, these are our main questions that we have to just discuss or talk about. So, this was a simple case of the left leg cellulitis. The person who was starting antibiotics, and his treatment was very predictable that if the antibiotics um, respond like to his symptoms, then he would have gotten better, and then he would have been discharged in a day or two. But what happened wrong here that his home blood pressure medications, they were not continued inside the hospital, and that caused his hypertensive crisis. So, on the further evaluation of the cause of the hypertensive crisis, it was relieved that in his home medications they were not properly reconciled during the hospital stay, and as he had resistant hypertension, his home dose of clonidine was not continued as a part of his hospital medications that resulted in the rebound hypertension and the hypertensive emergency with acute pulmonary edema and unstable angina. So, if we say that was it preventable, yes, obviously it was very much preventable, and this could be life threatening for this patient. Obviously, he's an old patient, 60 years old, and then if he has the hypertensive emergency, it can lead to acute heart failure, it can lead to the stroke, MI, unstable angina. So, just a simple negligence of, I would not say negligence like a medical error, that was an error of omission in which his home medications, blood pressure medications, they were not continued in the hospital, that has led him to this complication. So, that was just the base of my research topic. So now I will just overview some of the things that are related to the medication errors and the medication reconciliation. So first of all, there are two terms, that's polypharmacy and non-adherence. The polypharmacy is defined as taking 5 or 4 or more medications, and the burden of polypharmacy nowadays is variable, ranging from 10 to 90%. It's basically because a wide variety of the medications and the treatments are available, and that's why the patients are taking these medications for the treatment of the various diseases. And then there is another term is non-adherence. It means that when the persons they are not taking the medications according to their prescriptions or as the providers have prescribed them. So both these conditions, polypharmacy and the non-adherence, they can lead to the occurrence of the medication errors. So, what is a medication error? It is defined as a failure in the treatment process that leads to or has the potential to lead to harm the patient. So, why it's important to study about the medication errors? Because medication errors, they are the eighth leading cause of death in US these days, and these errors are responsible for 7,000 to 9,000 deaths in the US every year. That's a huge number. And other than that, increase in the mortality, it's also related to the healthcare cost. The US spends more than 40 billion each year on the patients who have been affected by the medication errors. So just imagine for a moment that if we have a good process in place to prevent these medication errors, how much money we can save and how much medication errors we can reduce that can reduce the morbidity, mortality of the patients. Now, moving toward the next part of my literature view, that's basically about the medication reconciliation. So, medication reconciliation, it is one of the ways to mitigate the medication errors in the health system. So, how we define medication reconciliation? According to the Institute of Healthcare Quality, IHI, medication reconciliation is defined as the process of creating the most accurate list possible of all the medications a patient is taking, including drugs, name, dosage, frequency, and route, and comparing that list against the physician's admission, transfer, and discharge orders to provide the correct medications to the patients at all transition points within the hospital. Medication reconciliation, it definitely improves the patient safety. That's why Joint Commission, it recognizes medication reconciliation as one of the patient safety goals for all the US hospitals. And medication reconciliation, it's crucial in every step of the hospital process, like admission, transfer, or at the time of the discharge. But some of the studies they have shown that it's most important at the time of the admission. So, medication reconciliation, if done appropriately on admission at the hospital, it can potentially reduce adverse drug events by 43%. And another study highlighted that medication order errors they are most prevalent at the time of the admission and occurred in 36% of the patients. So that's also related to my patient population. That we have to implement medication reconciliation for the admitted patients. Okay, so now I'll just explain that what is the process of medication reconciliation. It means that we have to gather the best possible medication history of all the medicines the patient is taking. It should include the herbal medications, supplements, over-the-counter, the prescription medications, and respiratory therapy related medications, for example, inhalers, that should also be added for the drug interactions and in general to the medication list. And then for each medicines, we should know the name, strength, dose, route, frequency, and also when was the last dose of the medicine was taken. So now, progressing towards my research topic, I have just enlisted the barriers to the reliable medication reconciliation process. So I reviewed some of the studies, and they mentioned few causes that I have listed here. So first cause is that physicians and pharmacists they do not consider patients a reliable source of information to perform the medication reconciliation at the admission. So this scenario applies on the situations where the patient they are in acute delirium or they are in not a stable condition to provide their medication history. So in that situation, the physician or pharmacist they don't consider patients as a reliable source. And then another cause was that medical providers they're performing multiple clinical tasks simultaneously, or they're taking care of high number of the patients, or they're dealing with many sick patients at the same time, and that is a hindrance for performing the reliable medication reconciliation. Then, few other causes are the lack of adequate reconciliation training, communication gap among the providers, absence of culture, or the poor understanding of the roles, inadequacy of an interdisciplinary team approach, and the absence of a robust system to maximize medication reconciliation. So now that we know the barriers of the medication reconciliation, we should also know the stakeholders for conducting this medication reconciliation process. So basically, it is a team-based approach in which not one person is responsible for conducting the medication reconciliation. It's basically a team-based approach in which the patients, their families, relevant physicians, pharmacists, and other providers, they all are involved, and this process requires some training. And then we should also be needing a computerized system that can help with a well-planned medication reconciliation system. Like and then we should also have the clear role allegations, and lastly, the automated electronic system in place. So all these factors, when they work together, it results in an effective implementation of the medication reconciliation process. So now that we know the barriers that in the effective medication reconciliation process and the stakeholders we need for the MR process, I will just list the purpose of this literature review. So I am interested to identify the available evidence and the best practices for the medication reconciliation processes, and then to compare and contrast the effectiveness of the various available tools, and then to identify the gaps in the literature for the further research and provide a practical guide to medical providers to improve the reconciliation at admission. This in turn will improve the patient safety, prevent the avoidable harm, and reduce the healthcare expenditure, which are our ultimate goals. So I have enlisted my research question here. I will just read that. My question was, what are the best practices in place to optimize medication reconciliation at the time of the hospital admission in adult patients? So my research is concentrated basically at the time of the admission and then on the adult patients only. So what methods we have used? It is a systematic literature review in which a focused research question was created using the PICO model. Various sites like PubMed, Google Scholar, and Medline, they were searched for the key search items like the best practices, barriers, medication reconciliation, and best practice guidelines. These kind of the terms they were used for the search. And then inclusion exclusion criteria was applied, and the duplicate studies they were removed. Inclusion criteria was the articles published in the last 10 years, but preferably between the last 5 years, 2017 and 22. And then the age group I included was adults 18 years and older, and then the availability of access to the full text free of cost. And then the exclusion criteria applied to the studies conducted in the pediatric population, like less than 18 years of age. I excluded them. And if the full text was not available free of cost or University of Mount Union Library, it was excluded. And then obviously the articles not available in the English language, they were also excluded. So now coming to the results, this is a slide that's just an overview of all the 6 studies that I analyzed in detail. The secondary data was used in this literature review, and 5 of my studies they used the quantitative research data, while one of them used the qualitative research data, and 3 of the studies they were observational study. While one of them was a systematic review, one was a randomized controlled trial, and one was a retroactive study. And there was no control group used in any of these studies. And if you see in the slide, I have mentioned just the like the summary statements for the various interventions used in the medication reconciliation processes. So my first article, Esther et al., basically talked about incorporating the educational PowerPoints for training the medical providers to improve the medication reconciliation process. Then the next, Karai, just forgive me for my pronunciation. I think it's Karai et al. They talked about the pharmacy-led medication reconciliation processes. And then Manias et al. They talked about involving the family members in the MR processes. And then Srusi et al. They mentioned about using the Easy MedRec decision support system for conducting the medication reconciliation. The next was the Dortenzenberg et al. They talked about the medication reconciliation with the patient education to reduce the hospital readmissions. So they gave another dimension to the medication reconciliation by not talking about the practice guidelines, but by mentioning that if we have effective medication reconciliation processes in place, then we can reduce the hospital readmissions, and that can in turn reduce the hospital waste. And the last study was Hop et al., and they talked about the conducting the medication history uh, through the technicians to reduce the medication errors, to improve the medication reconciliation processes, and also the study um, worked on highlighting which group of the people or the population they are at a high risk of having these kind of medication errors. So that was just an overview, and now we will talk about each study one by one. So my first study is Lester et al. The purpose of this study was to show the importance of incorporating educational PowerPoints in hospital gang downs as an essential tool to improve compliance with the MR. So in the method, they first created a medication reconciliation committee, and then the education module was created in a PowerPoint format based on the existing literature, and it was used to teach the importance of the medication reconciliation to their staff during the grand round. Clinicians with extensive experience, they were used to assess the validity, feasibility, and the utility of this course content. The education module was then implemented in the multiple telemedicine and surgery grand rounds and utilized to teach the students, trainees, and the attending physicians. So, in the results, approximately 150 learners they attended this session, and their learning was assessed with the pre and post self-assessment surveys. 74 completed the pre-course surveys, 39 completed post-test surveys, and 49 participated in the audience response during the course and multiple choice knowledge questions. The result of the post course knowledge assessment showed improvement in every question tested, with two of the improvement reaching statistical significance. And then 30% of the attendees they were not at all confident or only somewhat confident in conducting an appropriate medication reconciliation on admission to the hospital. And 82% of the respondents they reported that the presentation was likely or highly likely to improve their MR efforts. So, so there was just one limitation of this study that only the articles published in English they were included. So now moving to our second study, that's Keroy et al. The purpose of this study was to find the clinical impact of pharmacy-led medication reconciliation performed on adults at the time of admission to the medicine service in two tertiary care hospitals. So what methods they used that the student pharmacists they were asked to take detailed medication histories from the patients after being adequately trained and under supervision. Medication at the transition and the clinical handoff match toolkit from the medication from the Agency of the Healthcare Research Quality AHRQ that was used for the medication interviews. So that was the standard match toolkit that was used here. And later, pharmacists they were asked to conduct the medication reconciliation and verify the students' findings. And unintended discrepancies they were communicated to the medical team actively. And the outcome measure that was used here was the incidence of unintended discrepancies classified by the route of administration, severity, proximal cause of the discrepancy, and the medication class. What we found in the results of the study included 204 patients with equal gender distribution and a mean age of 70.5 years, and majority were they were using multiple medications. So the study identified 195 unintended discrepancies in 94 patients. The most common discrepancy was the medical omission, and the most common agent involved they were dietary supplements. So I have highlighted this most common discrepancy of medical omission because if we just go back to my clinical visit, what happened there? The same kind of the medical omission happened there, that the omission error happened, and they just in the hospital, um, the patients home medications they were just missed to be started in the hospital, and that caused the hypertensive crisis in that patient. So this study proved that finding. And then we found that around 36% of unintended discrepancies were clinically significant, and only one were considered severe. Most common intervention included the addition of medications and adjusting doses. And then we've also found that the number of the home medications were significantly associated with unintended discrepancies. So again, this is highlighted here because it just was found true in our clinical vignette, where the patient's home medications, antihypertensive medications, they were not started inside the hospital. So now moving to our third study, Manias et al. The purpose of this study was to analyze the involvement of the family in managing the older patients' medications across the transition of the care between the hospitals, homes, nursing homes, etc. So you know that many times the older patients they depend on their family members or the caretakers to take care of their health and the medications also. So, what methods include here is that it was a systematic review and included 23 papers consisting of 17 qualitative studies, 5 quantitative studies, and 1 mixed method study. Families they were defined as former relation of older patients or other significant individuals who played an important role in older patients' lives. And families' participation was in the form of giving and receiving information about the medications, making decisions, managing medication complexity, and supportive interventions related to managing medications for the older patients across the transition of care. So, what they found in this study is this study was unique because it not only highlighted the importance of involving the families in managing the medication of the older patients to reduce the medication errors, but also it talked about the barriers in the family and the medical providers communication. So, what were the barriers that we found in lack of the shared decision making between the families and the providers? So, the barriers we found were the time constraint, that physicians or the medical providers they are short of time to communicate with the family members, understaffing, heavy workloads. And then the study is also important because it guides health professionals that how they can effectively engage families um, in the hospital stay. The suggestions that this article gave, that the healthcare providers they can designate family meeting times, they can talk to the patient's families during the clinical beds and handovers, ward rounds, or admission and discharge consultations. So, the limitations of this study is that, again, the articles published only in English they were included. And then another thing was that most papers didn't specify a focus on the objective of this review. So, it was sometimes hard to extract the data. So, now moving to our next study is Sorosi et al. The purpose of this study uh, was to find another unique way of conducting or improving the medication reconciliation process by a retroactive MR process at the hospital admission by using the Easy MedRec decision support system. That was a very unique idea that I found. So how they use the system? This automated system detects and classifies the undocumented discrepancies by comparing the best possible medication history to the list of the admission medication orders. The most distinct point of using this tool is that the drugs are decomposed based on their active ingredients. It was assessed on a sample of 52 actual retroactive medication reconciliation to evaluate its accuracy concerning NMR, gold standard built by expert pharmacists. So what they were doing, that they were conducting the medication reconciliation process by the expert pharmacists, and then they were conducting the same medication reconciliation process by using this easy metric system retroactively, and then they were comparing their results. So the sample of 52 actual medication reconciliation forms refer to a total of 822 medication order lines, 406 in best possible histories, and 416 in the uh, admission medication orders. Each drug is displayed with its label, active ingredient form, administration route, daily rhythm, dose, and treatment durations. And firstly, a proposed list of formal discrepancies that occur between the drugs and the AMO. They were created, and then the Easy Medrec support system findings, they were compared with the pharmacist's findings. So what they found here, this study actually showed that 808 medications were correctly categorized by the Easy Medrec system, resulting in accuracy rate of 98.3%. However, there were some limitations of this study, that the sample size was very small, like of only 52 Medrec cases. And then the Easy Medrec relies on drug resources issued from the National Agency for the Drug Medicine Safety in France, and resultantly depends on the structure and the contents of databases. So this system was just used in the France, and this database may not apply to other hospitals in France, or may not apply to the other hospitals of other countries in general. And then the Easy Metric is developed as a prototype, although its usability and results are promising. But this automated decision support system needs to be utilized in the larger samples and the other hospital settings to validate the metric process. Now we are moving to our next study, that is Dodzenberg et al. The purpose of this study was medication review combined with the co-interventions like medication reconciliation. Patient education and training of the healthcare professionals can effectively reduce all-cause hospital readmissions within 30 days. So it gave another dimension to our medication reconciliation process, because instead of giving us some practice guidelines, it is telling us that if we have an effective medication reconciliation process in place, we can reduce the hospital readmissions in the next 30 days. And as a result, we can reduce the patient harm and we can reduce the healthcare waste. So, a randomized controlled trial was used in the study with 25 studies included. And out of these, 11 studies contributed to the network meta analysis of all cause hospital readmissions within the 30 days. So, what were the results? Two interventions that were associated with a statistically significant decrease in hospital readmissions. They found that when the medication review is combined with the medication reconciliation, patient education, then it has a confidence interval of process improvement of 95%. And medication reconciliation, patient education, professional education, and transition of the care, they're associated with low risk of all-cause hospital readmissions. Whereas if the medication review is done in isolation without the medication reconciliation or the patient education, then it doesn't have much significance. So this study explicitly showed that incorporating medication reconciliation along with other co-interventions like the patient education and the medication review, it can reduce the hospital admissions and resultantly reduce the hospital cost significantly. The limitation of the study was that there were some concerns, mainly regarding the allocation, concealment, blinding, and contamination in almost 76% of these studies. So that's a huge number. Now, moving to the last study of my review is the Allen Hope et al. The purpose of the study was to highlight how hospital-wide medication reconciliation programs can impact identifying medication errors at the time of the hospital admissions, demonstrating the cost effectiveness of this program. And then another purpose of the study was to identify the individuals who are at high risk of medication discrepancies. So, in the method part, they used the trained medication history technicians um, and assess their competency, who take the best possible medication history from the patients at admission. And then the best possible medication history by these technicians was obtained using the Marquis implementation manual guidelines via the interviews of the patients, patient caregivers, transferring hospital documentations, electronic health records, reviews, patients' pharmacies, and the provider's office. The study enrolled patients 18 years or older without any exclusion in gender, ethnic background, or the health status. The frequency and the type of medications error they were recorded. Cost avoidance estimation, they were compared against the cost of the medication health technician programs based on the expected adverse drug event rates. And then the logistical regression analysis was used to test for the association between the medication errors and the patient characteristics. And the results were considered significant if the p-value was less than 0.05. So we found some interesting results from the study. It included 817 patients with the mean age of the patient being 60. Before the implementation of the medication health technician program, nursing staff within the hospital, they perform the medication, best possible medication history less than 50% of the times. That after the implementation of this medication, health technicians improved to 90%. That's a huge change. And then before the implementation of this program, nursing staff was spending an average of 5.7 minutes on the medication history, while after the medication history technicians program implementation, it was improved and increased to average of 28.5 minutes of taking the medication history of the patients. So that is a great change as well. An average of 6.1 potential errors per patient they were identified. Omission of medications on admission was the most common discrepancy in 82% of the patients. Again, I will just mention about my clinical vignette in which the error of omission occurred with our patient. Commission errors occurred in 59% of the patients. Dosing and frequency error, they occurred in 50% of the medication histories. And this program estimated cost avoidance of 210.33 per patient. Moreover, female gender, age, and high alert, high risk medication use, they were linked to increase in the likelihood of medication discrepancy. Um, this study clearly shows that the most medication errors of omission they occur at the time of the hospital admission. And I would like to mention here that that's why uh, I chose the patient population of older patients and at the time of the hospital admission in my research review, because that's the most vulnerable point where the patients can have the medication errors. So this is the only study in my research review that has the maximum number of the limitations. So low control groups were used here that allow monitoring for several errors with the baseline. It followed the Society of Hospital Medicine's best practice recommendations that the best possible medication history be completed by someone other than the admitting provider to maximize the identification of the unintentional errors. But it did not have a comparator group to evaluate whether the admitting providers they would have identified similar errors. And then the attempts were made to observe the differences in ethnicity, race, and primary language. However, the homogeneity of the patient population at the Midwest Hospital, where the study was conducted, it did not allow for the significance analysis of these factors. So that was a failure. Mm, though this program involves multiple hospitals within their institution, but the study was basically carried out in one largest hospital. That was another limitation. The study focused solely on admission, medication histories, reconciliation, so the result may not be generalized to level of the transition of care, like at the time of discharge or at the time of the surgeries, etc. Finally, the cost estimate and rate of the adverse drug events that primarily derived from the two studies from 1995 to 1997. So adjusting of the inflammation that may not account to the actual cost at the time of the study. So that completes the description of all my studies in detail. So now moving to the discussion of what we have learned so far. So here I have just enlisted all the best practice guidelines that we have obtained from all these studies. So our first study, it mentioned that if we regularly incorporate educational PowerPoints in the hospital grand rounds, then we can improve the medication reconciliation process. Our second study, it mentioned that the pharmacy students and pharmacists, they can be essential hospital team members in conducting the medication reconciliation process, and basically conducting the effective metric process. That's a multidisciplinary team approach, and it is not responsibility of just one person. The third study, it mentioned that we can involve the families in managing older patients medications during the transition of the care. So not only the patients but the families should all be involved in this process. The next study, it mentioned that how health professionals, they can improve the involvement of the families in the medication reconciliation process by arranging the designated family meetings, communication during the clinical bedside handovers, ward rounds, and at the time of the admission and discharge. Then another study introduced the process of the easy metric decision support system and improving the metric processes. And lastly, the benefit of complying with the medication reconciliation in reducing the number of the readmission in the older patients. So was one of the study that showed that the medication reconciliation processes, if done effectively, they can reduce the hospital readmissions. So, in general, if we talk about the limitations of all the studies we had, any of them didn't have any control group. Then two of the studies, they had the articles only in English. One of the studies include the risk concerns about the allocation concealment in almost 76% of studies, and that's a huge number. That reduces the importance of that study. And then one of the studies, it had a very small sample size of 52. So these were the limitations related to the studies. If I talk regarding the limitations of all this review that is done by me, I would say that only one researcher was involved in conducting the study, so that's a potential bias in search selection and the review of the articles. Then I have chosen only those articles which were available in English, so maybe some good research work that has been excluded based on the language bias. Lastly, search items they were used to narrow down the research might have excluded some of the vital research work. So, what are my recommendations for the future? So, based on what I have learned by all these reviews, I would say that we should implement all these practice guidelines on a larger study population, and if we can get a chance to carefully match the control groups as well to compare and contrast our results more effectively, that would be a good thing. And then I would say that once a standardized hospital-wide training system is in place and we have adopted a multidisciplinary team approach in the pilot unit, then it can then be should be spread to the other patient settings like outpatient, etc. Always we should use the process improvement indicators so that we can quantify the improvement of the metric processes after the implementation of our changes with the baseline. For example, reduction in the number of the readmissions and any other process improvement indicators, they should be the part of the process. And then I would say that research can also be extended to include the pediatric populations or the gender specific populations to find out that which age group is more liable to be affected by the lack of the MEDREC processes. And then our interventions should be directed in that particular age group. Lastly, I would say that my research was limited only to the admitted patients' MEDREC processes. So further analysis they can be carried out in other different patient settings like the outpatients or the urgent care, or even at the time of the discharge from the hospital, and that would be another good addition to the extension of this review. So I would just end up my research review with this slide. That's take home message or the conclusion of my literature review, that what are the things that we got from this whole review and study. So I got four important points here, that medication reconciliation, it is beneficial in reducing the avoidable hospital cost if you have a good MEDREC process in place. Secondly, MEDREC process, it's a multidisciplinary team approach where the clinicians, pharmacists, and students, they all work together for the medication reconciliation, and it's not on one person's or one provider's responsibility. It's just the teamwork. The third thing is that regular training of the hospital staff and the placement of the standardized electronic system, they are the basic necessities for the good MEDREC process in place. And lastly, the family members, they can be effectively involved in MEDREC processes, especially in the older patients. So if we give importance to the history from the patient, we should equally involve the family members, especially for the older patients. That's really important to know. And with that, I would just end my this review. I have few more slides for the references that I have listed here, and I would just end on the slide where I would thank you for listening to me, and all the questions and the comments, they are most welcome, and I would dash my email. If you have any comments or anything related to this review, kindly leave me a message at my email, and I would get back to you. Thanks a lot and take care. Bye.